Well, good evening and welcome everyone. Thank you so much for joining us for another wellness webinar series event with Jefferson Health. My name is Sarah Breckbill and I will be serving as the program facilitator and will present your questions to our experts. This evening, we'll discuss all things prostate health, when to begin screenings, and what to look for when choosing a urologist, and much more. Well, thank you so much for submitting your questions in advance of tonight. And the questions that you'll hear me asking the providers are all submitted right from when you registered for this webinar. Now, if you have any questions throughout our discussion tonight, for those joining us on your computer or tablet, at the bottom of your screen, you should see an icon that says Q&A. We'll do our very best to get to as many questions as possible, but may not be able to answer all of them during this virtual event. And due to hospital guidelines and privacy, we are unable to comment on specific cases. Well, without further ado, I want to go ahead and introduce our experts for the evening, starting with Dr. Michael Greenberg with radiation oncology and Dr. Adam Mitwali with urologic oncology. Well, thank you both for joining us tonight. I'll give each of you a minute or two to just say hello, provide a little background information about yourself, and then we will kick it off with the questions. So Dr. Greenberg, we'll go ahead and start with you. How are you doing this evening? And I think you might be on mute.
There we go.
Perfect.
Thank you so much. And I appreciate the invitation to be able to speak along with my colleague, Dr. Metwali. And so I'm a radiation oncologist, and with radiation oncology, we treat cancers with radiation therapy, and prostate cancer is certainly one of the very common malignancies that we treat here at Jefferson, as well as in all of our satellite facilities.
Okay. All right. Well, thank you so much for joining us. And Dr. Mitwali, how are you doing this evening?
Doing great. Thanks for having me. My name's Adam Mitwali. I've been at Jefferson for about a year and a half now. Prior to that, I spent the previous 15 years or so in the Washington, D.C. area. Most recently, I was the chief of urology at Howard University Hospital, and prior to that, I worked at the NIH. I'm originally from California, and I did my urologic oncology fellowship at MD Anderson and also at the NIH. I'm happy to be here. For those who don't know what urologists or urologic oncologists do, urologists are basically the surgeons of the urinary tract. So, kidney, bladder, ureter, penis, testis, that kind of thing. We don't do the dialysis stuff. We fix structural problems in the urinary tract, and that includes surgery for prostate cancer, which is what we're going to talk about today.
Okay. Well, thank you. With that, let's go ahead and dive into the questions. I know we received a ton of submitted questions from the audience. So we will start with Dr. Greenberg. So first question for you. How do genetics like the BRCA2 affect your chances of getting prostate cancer?
Well, certainly with a BRCA2 gene or with other genetic predispositions, such as with a family history, there's a marked increase in a risk of getting prostate cancer. So, in family history, it can be as much as 5-fold, which is why usually we try to start screening programs with PSA 10 years earlier than we ordinarily would say in a general population where there's no history of genetic or family history.
All right, thank you. Okay, going along to our second question here, Dr. Mitwali, how safe is active surveillance, and is there a point where someone waited too long?
Great question. Active surveillance is very, very safe. I think the important thing for people to know and understand is that the vast majority of men who are diagnosed with prostate cancer will not die from it. In fact, they die with it, and they typically die from heart disease, believe it or not. So even though there's, 200,000 or more men per year diagnosed with prostate cancer, only about 35,000 per year will actually die from it. And those are men who are diagnosed typically many years, even decades earlier. And so the trick with managing prostate cancer is None of us has a crystal ball. We don't know exactly when you're going to die or what from. And so we have to do this concoction of trying to figure out how long we think you're going to live, what other comorbidities you have, and then assess that relative to whatever the prostate cancers that we identify. And most prostate cancers, the vast majority of them, are low grade and low volume. And when you sort of spin that forward over time, you're talking about, decades before it's going to get to a point where it's actually going to cause a problem. And, often in the cohort of men in which prostate cancer is diagnosed, they're not going to live that long. The average life expectancy for an American male is about 76, give or take. And the average age of diagnosis for prostate cancer is in the 60s. So, we're sort of kind of pushing up against that 10-year life expectancy. So in cases where we think that somebody maybe has a bad heart, bad lungs, has a family history where everybody kind of drops dead at 70 of this, that, or the other thing, then if we diagnose a prostate cancer and it's not a particularly high grade, PSA is not especially high, the volume of the cancer is not very high, it's safe to watch it, and it's safe to watch it for a long time. The active surveillance studies that were done, they started doing them, 20 plus years ago, have shown that there's really no decrease in outcomes, even after you watch people for 3 years or more. And some of the people have been on active surveillance for, 10 years and that kind of thing. So, it's one of those things where you can watch it for a good long time without sacrificing outcomes. It's not to say that nobody ever progresses on active surveillance. People do. But the window for therapeutic treatment is really wide when it comes to prostate cancer.
Okay. All right. Thank you for that. All right. Next question here. And Dr. Matwali, this one is for you again. What are some early warning signs of prostate cancer? And at what point should someone contact their physician?
Well, any change in your urinary symptoms is probably the first place to start. Now, it turns out that the things that cause that are more likely not to be prostate cancer than are. But certainly if you're a man in your 50s and 60s and you notice a change in your urinating, especially if you're getting up at night to pee, or you feel like your urine stream is not as strong as it used to be, or now you have to push a strain to get going, it's time to come see someone like me so that we can get that sorted out. The fact is that most prostate cancers are totally asymptomatic. And so that's why Dr. Greenberg was talking about PSA screening. And we typically start that around age 50 for most men. If you have a family history of prostate cancer, in a first degree relative, that means, a brother, a father, maybe a grandfather, that we might start it a little bit earlier. There are certain groups that are a little bit more at risk. People of African descent are typically screened a little bit earlier, maybe 45 or 40. And so the vast majority of prostate cancers are actually picked up and they're asymptomatic based on changes in the PSA.
Okay. All right. Thank you. Dr. Greenberg, turning to you for a minute here. Are there any non-invasive ways to treat prostate cancer?
Yes. So radiation with external beam radiation is a non-invasive way to treat. So it's really high energy X-rays, which are focused to treat the prostate. Now, this has come a very, very long ways. Years and years ago, this was just directed to what we used to call the belt line or the waist, and patients were burned. They had rectal bleeding. Like with any specialty, things have come so far. And now we can treat patients. We've come from 45 treatments, 48 treatments down to 5 treatments. And we're treating with MRI guidance during the treatment because lo and behold, when we thought we were very good, we found out, wow, the prostate moves during treatment. And it moves because of filling of the rectum with gas or stool and filling of the bladder. So it's a dynamic process. So we now have very sophisticated, again, non-invasive ways with MRI, which actually are focusing and are imaging with MRI during the treatment, which means the least amount of normal tissue in the field. So that's a non-invasive way to treat prostate cancer and found to be very, very effective.
Okay, Great, thank you. All right, Dr. Matwali, before we turn back to you, I just want to remind the audience, feel free to submit any questions that you have. Once we get through the submitted questions, we'll then turn to live questions from you all. Okay, so our next question here, what are the factors that lead to prostate cancer in men?
It's a great question. There are some genetic mutations that predispose people to developing prostate cancer. Dr. Greenberg talked about the BRCA when he answered the first question. And I mentioned earlier, if you're of African descent, there appears to be earlier age of onset and, that sort of thing, higher incidence. So those are factors. Now, once you get past those, it becomes a lot less clear. People have been looking at dietary impact, other exposures and things like that. And there really isn't anything that stands out definitively. Because, there's an obesity epidemic in the United States, there's some correlation between obesity and developing prostate cancer. Some people have drawn a parallel between eating grilled foods and the development of prostate cancer. I think that those correlations and connections are a lot weaker. So I don't know that I would say that definitively, but certainly there's some data out there to suggest that might be the case. Cigarette smoking is bad. It actually increases your risk of all kinds of cancers, bladder cancer, kidney cancer, and yes, prostate cancer too.
Okay. All right. Thank you. Okay. Dr. Greenberg, I want to go back to you for a second to talk a little bit more about treatment. Can you talk about the use of the linear accelerator in treatments?
Yes, so a linear accelerator is a machine that produces high energy focused X-rays. So we start the process with a regular diagnostic imaging, such as a CAT scan or a CAT scan and MRI, or even PET scan. We add them all together to help define our target, or being the prostate. And once we do that and we come up with a treatment plan, which basically is designing the radiation fields to treat the target to a specified dose and to limit the dose to all the critical structures, which would be the rectum, the bowel, the bladder, the bones, such as the femoral heads. We finalize that, and then the patient is put on the linear accelerator, which is a machine which generates the high energy X-rays through electrons. So the machine, actually, you lie on a table and the machine rotates around you. You're on a flat table, which is very flat, and the treatment itself on a standard linear accelerator, usually beam on time is less than 2 minutes. And that is treating, there's little micro leaves inside of the head of the machine, which is or are moving in and out to help shape the field to treat the target. Now, in general, the prostate is a sphere or sphere-like. So it's an easier target for us to treat than many other targets, which are much more obtuse. So it's very, very well defined for a linear accelerator to do that and limit the doses to the normal structures. You won't feel anything. It's an X-ray. So it's not something you will feel burning or anything from the actual treatment during the treatment itself.
Okay. All right. Thank you. Okay, Dr. Matwali, going back to you, would love to discuss here focal therapy for prostate cancer treatment and just get your thoughts on that.
With pleasure. This is a relatively new program that we are doing at Jefferson, and we are one of the first in the area to start really looking into this as an alternative to radical surgery or radiation. The concept here, and of course, not everybody is a candidate for focal therapy, but the concept is that there's a large number of patients where only part of the prostate is affected with the cancer. And so much like we did with, breast surgery, where they used to take the whole breast off and then they started doing lumpectomies, and with kidney surgery, where instead of removing the whole kidney, we just remove the tumor. We're looking into ways to treat just the part of the prostate that's affected with the cancer and leave the rest of the prostate intact. As I think most people know, when you treat the whole prostate, either with radiation or remove it with surgery, it can lead to some quality of life issues that are pretty unpleasant, whether it's, incontinence or erectile dysfunction or these kind of things. And so in theory, now that we have the ability with, advanced imaging techniques like MRI and, PSMA PETs and that kind of thing to really target where the cancer is, we can actually direct energy, whether it's high intensity focused ultrasound, cryoablation, where you freeze it, or nano knife, which is actually electricity, to destroy just that part of the prostate. The thinking being that you can treat the cancer and avoid a lot of the unpleasant side effects of whole gland treatment. It's important to know that, as I said, not everybody is a candidate, but also that it doesn't have the same long-term outcomes that radiation and radical surgery do. We've been doing radical surgery on prostates for, a lot longer than I've been a doctor, and same with radiation, and both techniques have about the same outcome in terms of being able to control prostate cancer. You sort of pick your poison on what you want to deal with in terms of side effects. Focal therapy, on the other hand, has only been developed over the last 15 or 20 years and is still in the evaluation phase. And because prostate cancer is such a slow-growing disease, you really need to be able to follow people for a minimum of 10 years and preferably longer to really figure out if it's equivalent or not. And so we're in that stage right now. Many of these modalities are FDA approved and you can use them, but the truth of the matter is that there isn't as much data supporting focal therapy as there is for, whole gland radiation or whole gland surgery. And we are in the process, we're at the cutting edge of getting that data and figuring out these outcomes and defining who is the perfect candidate for focal therapy. We've had some really excellent outcomes so far, but as I said, our experience is relatively early, and the national experience is still relatively early.
Okay. All right, but certainly exciting to hear. So thank you. Okay, Dr. Greenberg, turning to you now. So for the treatments that have been discussed, what can one expect during treatment? Are there any restrictions during or post-treatment? And how can side effects be minimized?
Right. So during radiation, there's no restrictions. Patients generally will work. We treat people who are retired. We treat golf pros, PGA golf pros, football players, baseball coaches. So people that are very active. Young people, we've treated people in their 40s. We've treated people in their 90s. So it's really a matter of their performance status and how they're doing. So how do we manage side effects? Well, the first thing is with the technology. It's just gotten so much better. So we have an MRI linear accelerator, and there's only about 60 in the world right now, so we are really blessed to have that. So we've talked about how MRI targets and helps us to really visualize the gland. So with an MRI linear accelerator, we are actually visualizing the prostate while we're treating. And any movement of that gland outside of like a 3-millimeter sphere, the beam shuts off. So that's incredible, because previous radiation, once you started, there's no adjusting. And we also adjust for any things that are moving, like suddenly if the patient was getting treatment and a gas bubble came down through the rectum and raised the prostate, the beam would shut off. Again, these are all things that cannot be done on other types of accelerators, including things like protons. So it's an MRI machine. The second thing is it actually tracks the movement of the gland and allows us to define the target and deliver different doses throughout the gland depending on where the actual cancers were. The second thing is, so since about 2015, the FDA approved something called rectal spacers. So we've all heard of patients, the story of patients getting radiation, and they're cured, but they can't leave the house because they have chronic bowel movements every hour or irritability. And that's a terrible situation. Well, the technology has gotten better, and we've limited our margins, and we've gotten better with defining the treatment and limiting the doses. But now we use rectal spacers. So I started doing them in 2016, And we've gotten to the point now where we're using something which is called hyaluronic acid. So this is a gel, 98.5% water. It's the same medicine that the plastic surgeons use in the face for reconstruction, for cheeks, for lips, and we don't steal any of the syringes, I promise. But it actually is done transperineally right through the skin, like the biopsies are done, and it helps to lift the prostate off the rectal wall. It moves with the rectum, so patients don't feel it with bowel movements, and it dissolves after a period of about a year to a year and a half. And that lowers the dosage dramatically to the rectal wall as much as 80–90%. So that has improved things as well. So, we've come a very long way with minimizing side effects. So patients, because quality of life is key, because patients, as Dr. Metwally said, the majority of patients do not die of these cancers, and we want them to just live their life.
Absolutely. Okay, very promising to hear. Thank you.
Sure.
All right, and Dr. Metwally, I know that Dr. Greenberg mentioned the rectal spacer. Is there anything else you'd like to add there?
Um, I think it's been a huge advance. It's medicine is constantly trying to improve our techniques and our ability to do things, and improving isn't just a matter of improving outcomes for cancer or whatever, although that is the primary goal, but also to make it more tolerable for the patient. And so this is a relatively minor procedure that's very, very well tolerated, but makes a huge difference when you go from, radiation hitting the rectum, which, like the bladder, the rectum really doesn't like radiation. And it's one thing if you got urgency and you got to run to the bathroom to pee. It takes it to a whole nother level if you have to run to the bathroom because you might soil yourself the other way. So, putting that tiny little bit of, hydrogel in there basically makes a massive difference and makes it so much more tolerable without sacrificing the effectiveness of the treatment. So, I think that it's a great thing that we have that available to offer to our patients.
Absolutely. Okay, thank you. All right. For our final question here, before we turn to live questions from the audience, which I know we've been receiving a ton, so thank you. Dr. Greenberg, this one is for you. Can one get radiation again for prostate or to other areas of the body?
You must have been reading my mind because that's exactly what I was thinking about as well. So the answer maybe 10 years ago or a little longer was no. But now with the technology, it's something that we do regularly. So the question would be is, well, if you have to do it again, is it effective? So actually, these are patients that were treated anywhere from like 2000, 2005, 2010, 2015, where we weren't able to account for movement of the prostate, or maybe the doses weren't quite as high, or the technology wasn't as good. Or sometimes when patients were treated with internal brachytherapy seeds and a certain portion on the top of the prostate, which we call the seminal vesicles, which help to create semen, did not receive radiation. So we actually do re-irradiation on the MRI linear accelerator all the time. I will say the hydrogel really helps us to do this because it definitely limits the dose to the rectal wall, so we can deliver these high doses and proceed for cure. So the answer is now it's something we do regularly.
Okay. All right. Well, thank you.
Sure.
All right. With that, I think let's turn to our live questions. So I will go ahead and read the question, and whoever wants to jump in, feel free. This is definitely, meant to be an open conversation. So yeah, welcome you to both to jump in. So the first question here, after radiation treatment for prostate cancer, how often should you follow up?
Uh, Generally speaking, after any definitive treatment for prostate cancer, we typically follow up every 3 months for the first year or two, and then every 6 months for a couple of years, then yearly after that. Because the natural history of prostate cancer is so long, we don't necessarily cut it off at 5 years like you hear about in some other cancers. But we try not to, overdo it. And whether or not you do it every 6 months or every 3 months, the second year or the third year or yearly, will depend to some degree on what your original tumor was. The less aggressive it is, maybe the longer we can go in between intervals.
Okay.
And it's interesting. A lot of patients will ask us, okay, so after my treatment, when do I repeat the PET scan? When do I repeat the MRI scans? And honestly, the PSA really tells us everything. And we follow those PSA trends to see how it's declining and to see if there's any information which shows us that it's starting to rise. Now, sometimes after treatment, and particularly after radiation, it'll rise 6 months, a year later, and then it'll come back down again just from inflammation within the gland. So PSA really tells us a lot of these things. We really don't do any imaging unless the PSA continues to climb. And then we usually would get a PET scan, a PSMA PET scan.
Okay. All right. Thank you. Next question here. Dr. Mentwali, I will turn to you for this one because I know you're talking about factors that may contribute to prostate cancer. This person is wondering what prevention can be done for prostate cancer, and can you discuss ways to encourage a healthy prostate?
Sure. It's a marvelous question because people have been looking at this for decades. And, as I mentioned earlier, most men who have prostate cancer die of heart disease. So I always recommend a heart healthy diet. Whatever that means. You want to keep your, cholesterol and your inflammation and everything else down. You want to keep your weight down and that sort of thing. Unfortunately, there's no good data on what you can do specifically to help your prostate and, reduce your risk of prostate cancer. It kind of comes back to the lack of information that we have, or our inability to find it anyway, about what predisposes somebody to developing prostate cancer. So I always recommend just a heart healthy diet, exercise, keep yourself fit, normal body weight, all those typical kinds of things. Those are the best ways to keep a healthy prostate.
Okay, thank you. All right. And this next question here, sort of a follow-up. What is the danger of living with a large prostate?
Yeah. So, most prostates that give people problems are not cancerous. It's called BPH, benign prostatic hypertrophy or hyperplasia. It just means an enlarged prostate. A normal sized prostate is about the size of a walnut, 20 grams or so. There are men out there that have prostates bigger than my fist. And how they urinate, I don't know, but some of them can without too much difficulty. So it's really hard to figure out why some people are really symptomatic with their prostates and other people aren't. But typically, when you have an enlarged prostate, it manifests as, reduced amount of time between voiding. So normally people can go 2, 3, 4 hours and, so they're peeing a handful of times a day. If you're urinating less than every 2 hours or every hour or every 15 minutes, obviously that disrupts your day in a big way. If you have urgency and frequency. And then the big thing as far as the health risk is when you get up at night to pee. Now, it's normal to get up once, when you get to a certain age, that's kind of unavoidable, I think. More than once is not great. The first question I'm going to ask you if you do that is, do you snore? And are you overweight? Because oftentimes, if you're urinating fine during the day, but you're getting up at night to sleep, it actually doesn't have anything to do with your prostate. But it actually has to do with undiagnosed sleep apnea, which causes you to make more urine at night. But in any event, whatever the cause is, whether it's sleep apnea or it's an enlarged prostate, if you're not getting good sleep, that does correlate with a higher risk of cardiovascular events, heart attacks, and that kind of thing down the road. And people who don't sleep well don't live as long. So, that's one of the major risks. The other risk that's very, very common in people with enlarged prostates is that they don't empty their bladder well. That can lead to bladder stones. That can lead to urinary tract infections, prostate infections, and testicular infections. So these are all, potentially risks of having an enlarged prostate. That being said, as I mentioned before, you can have an enlarged prostate and everything can work just fine. But common things being common, the bigger it is, the more difficulty you're going to have efficiently emptying your bladder, and that leads to all kinds of other problems.
All right. Thank you. All right, Dr. Greenberg, I will turn to you for this next question because I know we mentioned the BRCA gene earlier. This person is wondering how accurate are genetic tests for prostate cancer?
It kind of gives you a sense of what your risk is. And basically in prostate cancer, that you should start screening earlier. You know, as compared to things like breast cancer, where if a woman has a BRCA1 gene, and her risk for breast cancer are extremely high, she's probably going to get a bilateral mastectomy, as a prophylaxis to prevent the breast cancer. But in prostate cancer, we probably would start screening earlier, and I certainly would appreciate Dr. Mitwali's opinion on that as well. But it just shows a propensity or a higher risk, so we have to watch extra carefully so that we start the screening process so we can treat it at an early stage.
Yeah, I mean, these genetic tests that we do just kind of give you a probability of higher risk disease, more aggressive disease, metastasis, and that kind of thing. I always say this to my patients when I counsel them about, the genetic evaluation or even, complications, is that, I can tell you that it's a 60% chance of something, but for you, it's either 0 or 100%. It either happens or it doesn't.
Yeah.
The idea is to guide us to make a good decision by looking at the likelihood that something's going to happen. So, it's not 100% sure if you get a genetic test and it says you're high risk, the things are actually, if you didn't do anything, are actually going to progress rapidly. The cancer is going to spread and all that kind of stuff. That doesn't necessarily mean that. It just means you're more likely to than some other guy who doesn't have those markers.
Okay. All right. Thank you. Okay, Dr. Mitwali, this next question is for you, as I know you were mentioning it earlier. Is there anything that can be done for difficulty when urinating?
Oh, absolutely. There's a lot of different things that, really like a full menu. We typically start with medications. There's two classes of medications that we typically use. Alpha blockers, people might have heard of Flomax. That's kind of the workhorse drug. It just relaxes. The prostate is made up of smooth muscle and glandular tissue. And so the alpha blockers relax the smooth muscle. So there's just less resistance. If you think about, instead of trying to pee through a pinhole, it just relaxes it a little bit so that the urine can pass more easily. Bladder doesn't have to work as hard, and you empty more efficiently. And these drugs are very, very well tolerated. They do have some side effects, but most guys take them and they do just fine with it. The other class of medications are called 5-alpha reductase inhibitors, and they actually shrink the prostate, but they take a long time to work, 6 to 12 months to really get an effect. But they inhibit the conversion of testosterone to a more potent form of testosterone and can shrink the prostate by 30 to 50% by 6 to 12 months. It also will lower the PSA, which is kind of nice because sometimes when people have enlarged prostates and high pressure voiding, the PSA will bounce around a bit, which can be confusing and maybe lead you down the path of getting like an MRI or a prostate biopsy. And so this kind of avoids that. But between those two classes of drugs, when they're used together, it substantially reduces the risk of what we call urinary retention, which means you have a full bladder, but you can't pass your urine. And then if those medications don't work, there's surgical therapies. There's the TURP, which is like a roto-rooter job where you kind of scrape out the inside of the prostate. There are some, newer things like aquablation and Resume, which is basically water vapor thermotherapy. There's a bunch of different ways where we use various techniques to debulk the prostate so that urine can pass through more easily.
Okay. And this next question here might be a follow-up to what you're just saying. This person is wondering if there's any other medications you would recommend or natural ways to help with prostate issues. And are there side effects to non-surgical treatments?
Of course, there's no free lunch. Unfortunately, everything has side effects. As far as herbal things go, there's a million different things out there to treat prostatism, prostate symptoms, and that kind of stuff. I think the most common one is saw palmetto. You can get that at any GNC and pretty much any place that sells vitamins. It has a similar effect on the PSA as the 5-alpha reductase inhibitors by lowering the PSA a bit. So you have to let your doctor know if you're on it. The problem is that while it does have that effect, when it was studied very carefully, it doesn't really have any impact on your voiding. It's not any better than a sugar pill. And beyond saw palmetto, there's not a lot of data about whether some of these other things work. There's like milk thistle and pygeum and some other things. And frankly, the data that's out there supporting their use or undermining their use is all pretty much garbage. So it's really hard to know if they work or don't work. I would say by and large, in my experience, of course, there's a selection bias because people come to me because things aren't working well. I haven't seen any of these that necessarily works all that well. That being said, I don't discourage people from taking any of these things because if you feel like it works for you, you should absolutely take it. There's a 30% placebo effect rate. So if you think it's working and it feels like it's working, go ahead and take it. That's great. And because they're understudied, it may work with your particular, physiology to help you where it may not help most people. So I'm not opposed to it. It's just mostly largely unstudied for the herbal stuff.
Okay, thank you. All right, next question here. Does it make it more difficult or limit treatment if on surveillance and the cancer is minimal?
I don't understand the question. Can you repeat that?
I think what they're saying is that if you're on surveillance and the cancer is minimal, does it make it more difficult or limit treatment? I
Hmm.
don't. If we don't know, we can skip to the next one.
I mean, it would depend on what we're finding at that time. So, what would the grade of the cancer be? What's the PSA? How much cancer there is in the gland? And if it's an early cancer and it was been under surveillance, which is usually the case, so there's not that much change. As far as radiation goes, it usually means that we can treat sometimes with a little lower dose. We can treat in small amount of fractions, like stereotactic radiation with 5 fractions, and certainly minimize side effects. We can use brachytherapy. So there's a lot of different things as far as radiation with early disease.
Now, maybe it just occurred to me that perhaps the question is, if you have an enlarged prostate, does that make active surveillance more complicated? And the answer
Okay.
to that is absolutely yes.
Yeah.
As I said, with enlarged prostates, avoiding difficulties, that can sometimes cause the PSA to kind of bounce around a bit. And then you have to tease out whether or not it's coming from the cancer or it's coming from the enlargement or, whatever. And actually, I find that the 5-alpha reductase inhibitor medications are very, very useful in this case because what it does is it increases the signal to noise ratio by reducing the PSA that's produced by the benign tissue in the prostate. It doesn't really affect the PSA that's being made by the cancers. And so if you see fluctuations when you're on those medications, that is actually more concerning than if you see it in the absence of those medications because there's so many other confounding reasons why the PSA may be jumping around. So if that's the question, then the answer is, unequivocally yes.
Okay, thank you. All right, next question here. Are there alternatives to a prostate biopsy?
No.
Yeah.
Short answer is no. So, we are getting to the point with our imaging where we may not have to do biopsies quite as often. But as it stands right now, there is no substitute. Most people will not treat you without doing a prostate biopsy. Certainly, I think you'd be very hard pressed to find any surgeon who would do a surgery on you without a tissue diagnosis from a biopsy proving that you have prostate cancer. I think the same is true for radiation.
Yes.
And so while the technology with PSMA PETs is improving to the point where you can maybe from here see the future where we might be able to just rely on that and not do the needle biopsies of the prostate. Right now we're not at that point.
And I think where the bigger question probably comes is if you have an elevated PSA, does every person have to be biopsied? And I think sometimes, you tell me, Dr. Madwala, if you agree, that the imaging helps us. If an MRI scan is very definitive for a lesion versus not definitive, does that guide you in doing biopsies?
100%. Absolutely. And that's, part of what I was saying about the improvement in these technologies. We are doing less biopsies now than we used to because we have the MRIs. And if you have a mildly elevated PSA with an enlarged prostate and you do an MRI and there's no area that's really suspicious for prostate cancer, a lot of us will now not do a biopsy there. We'll just kind of follow it along. Maybe we'll add you, give you one of these medications or something like that. So we are avoiding doing biopsies a lot more often than we used to when we didn't have imaging that could give us additional information. But that said, we're not doing away with it completely yet. As an aside, this wasn't asked, but I'm going to add it. prostate biopsies have advanced as well, much like Dr. Greenberg was talking about, some of the advances that have been made with, radiation. More and more, we're doing what's called a transperineal biopsy, where the needle actually goes through the skin, as opposed to a transrectal biopsy, where it will go through the rectum. That has substantially reduced the risk of infection. And it's not just prostate infection, but urinary tract infection, testicular infection, those kind of things. That has dropped dramatically because we're no longer putting the needle through the place where the stool is. So the probe, unfortunately, still has to go in the rectum for us to target the needling, the needle placement. But at least we've managed to make some progress in terms of being able to better sample the anterior part of the gland, where sometimes we missed tumors in the past, and also cut down on the risk of infection.
Okay. All right. Thank you. Next question here, and thank you again to the audience for these great questions. What are the pros and cons of radical surgery for prostate cancer?
Yeah. So that's a really interesting question, because the pros of radical surgery are the following. Number one, it's the best pathology you're going to get. There's an undersampling that occurs with biopsy, and it makes sense because if you have a prostate that's this big and you use a needle and you take, a dozen cores out of it, there's a lot of uncovered territory. So you may not know exactly how much disease is in there, and that influences treatments. If it turns out that there's high-grade disease, but you didn't sample it, you might get undertreated with some of these other things. And so that's the best pathology. We also often remove the lymph nodes in the pelvis, so that gives us, some more definitive idea about whether or not the cancer spread, at a microscopic level, into the pelvis. The other advantage is that after surgery, PSA becomes a very, very clear-cut test for the most part. The normal PSA assays don't detect below 0.1. And so as long as your PSA remains less than 0.1, you're disease-free. And if it starts to rise, then something's going on. Whereas you get a little bit of bouncing around of the PSA even after, treatment with radiation or with cryotherapy. So there's some confounding PSA, and you have to read the tea leaves a little bit. That's probably the best. And obviously, the cure rates for radical surgery is as good as, any treatment out there. There's not like one best treatment, but certainly, surgery is the mainstay and the standard by which all other treatments are judged. The downsides, of course, is that it's surgery. It's invasive. There's blood loss. There's side effects like incontinence. There's side effects like erectile dysfunction. And so, it's not a free lunch, and depending on how old you are, depending on what your erectile function is going into surgery, depending on what your urinary symptoms are before you go into surgery, really can, impact whether or not surgery makes sense for you. If you're over 70, your ability to regain control of your urine after surgery is just not that great. And so, maybe that's not the direction you want to go in. If you don't have erections at all, and you have terrible time passing your urine, then surgery is probably the best thing for you, because we're going to relieve the problem with the urinating, and we can't hurt your erections any more than you already have. So this is why we have to have these very detailed conversations with patients before treatment. And we, Dr. Greenberg and I work in the cancer center, and we go to the multidisciplinary clinic where our patients get to hear the pros and cons from the people who actually do the work. And we talk about, who you are, what your disease is, and what your voiding symptoms are and erectile function are, and which of these might be the best one for you. And then ultimately you have to make the decision yourself.
Right. And I usually, we certainly counsel the patients together, and I usually counsel the patients to talk about, what are their expectations, and how active are they, and what are they doing, in their particular life that day, and can they take the time for surgery, or is it something where radiation would be something that they would choose because they need to work. They can't, take off and things like that. So they're both good. They're both great, actually. And the techniques for surgery now have, again, like radiation, have changed so dramatically with robotics, which I think are incredible. I mean, to stay in the hospital, Dr. Metwally, now is what, maybe overnight? Is that right?
A lot of people go home the same day. I mean,
Yeah.
it's amazing. When I started this, the robot wasn't a thing. And, we kept patients in the hospital for 5 days, a week.
Mm, right.
The catheter, the tube that drains your bladder as everything heals together
Mhm.
used to stay in for like 2 weeks. Now patients at worst go home next day,
Which is
and the
incredible.
catheter comes out
Sure.
because we have this technology where we can do a watertight closure from the very beginning. Catheters come out in 4 days, 5 days. The blood loss has gone from a liter and a half down to, 5 ounces maybe, if that, 2 ounces in a lot of cases. So, the magnification with the robot is such that, you can see 10x what I could see with my eyes. And so the ability to see the nerves and spare the nerves so that they function after surgery has just improved so dramatically over the last
Right.
20, 25 years.
And computer technology and imaging is just driving all of our treatments now. In 5 years, we'll probably be treating even less fractions. And one of the things we didn't talk about with radiation is invasive types, and that's called brachytherapy. Years ago, patients have heard of putting seeds in, and they were radioactive seeds that stayed in the prostate and slowly delivered a dose of radiation. And I'm certainly old enough to have done many, like 1,000, and they were excellent, really, really good treatment. So now, and I just recently had a patient who couldn't come in 5 times because he lived on the upper border of Pennsylvania near Canada, and he wanted brachytherapy. And now we deliver it robotically delivered, where patients put to sleep and needles are put into prostate under ultrasound guidance. And we do that just twice, divided by 2 weeks, and treatment's done, and is equally as effective as our external beam radiation for early prostate cancer. So lots of great new things. And I think with AI, with artificial intelligence and more computer technology, we're just getting better and better.
Absolutely. It's really incredible to hear the advances. So thank you both for diving into that. All right. We have a few more questions to get through. So thank you to the audience. Next question here, a little bit more of a simple question. Is there a PSA level that is an indication of prostate cancer?
Short answer is no, but we use PSA. There's a threshold, and it's moved around since I've been doing this. I'm sure, Dr. Greenberg can attest to this. But we kind of look at 4 and then read the tea leaves a bit. If it goes above 4, we begin to worry about it. It doesn't mean you never have a prostate cancer with a PSA less than 4. That's not true. But as it goes up, the likelihood that the rise in PSA is from cancer and not from benign tissue increases to the point where starting to look for it makes sense. But it depends on age. So the older you are, the higher we're willing to accept the PSA being, without looking for prostate cancer. And the same is true on the other end. The younger you are, the lower the PSA should be. And, if you have a PSA of, say, 3, but you're in your 30s, that's not normal. That is something that probably needs investigation. And then again, this is one of the challenges of having like primary care docs do PSA screening and stuff like that, is that they may not know all these nuances, because you may not think of anything as a PSA of 3 in a guy who's 50, but if last year it was 1, that's not normal.
Yeah.
Whereas if last year it was 3 and 5 years ago it was 3, that's totally fine. So, there's a lot that goes into it. It's not just a number, but, the kind of thumbnail 30,000-foot view is below 4, you're probably fine. Above 4, we probably should start looking.
Okay, thank you. All right, next question here, is hormone therapy an option?
You want to take this, Mike?
Sure. So, when we talk about hormone therapy and prostate cancer, it's really a misnomer because it's taking hormones away. So it's male menopause, androgen deprivation, where we're taking the testosterone or androgens away. So we use it, and I'm old enough when I remember men at the VA were using DES, which was a kind of a synthetic estrogen. That's way back, and of course, it increased heart disease as well. But androgen deprivation is used in metastatic disease, and it's very, very effective. Um, Before we had all the medications that we used, simply what was done was that the urologist would remove the testicles, and that would basically remove the androgens and testosterone quickly. Of course, it wasn't reversible. But now we have medications that do that with shots or a pill, and we use it in different situations. We use it for metastatic disease, where the cancer has spread to, let's say, the bones, which is the most common. We use it in high-risk disease, where patients have high-grade disease, Gleason 8, 9, 10, where the patients have PSAs, where it could be over 10 or 20 or even higher, or disease outside the capsule of the prostate. And we do that for sometimes periods of 6 months or a year, or sometimes 2 years. So, and during that time, the men are living with testosterone levels which are 0 or close to 0. We really try to stay away from the hormonal therapy unless we need it in those indications, because it's not without side effects, which are menopausal side effects like hot flashes, weight gain, some muscle fatigue, myalgias, aches and things like that. So sometimes a little hair thinning. Again, with the medications, it is reversible. Adam, what do you think? What else would you add?
Yeah, I mean, I think that hormone therapy, as it's called, is a really tough part of this. The thing that makes us men, makes us hairy and horny and all this stuff is testosterone. And when you put somebody on medications that lower it way down, there's a lot that goes into it. You end up with hot flashes and muscle loss, weight gain. There's some cognitive fuzziness that goes along with it, that's not great. And so, it can really negatively impact your quality of life, and it's not curative. That's the thing I think is most important, is that the combination of hormone therapy plus radiation can cure prostate cancer, and does frequently. Hormone therapy doesn't really have a role with surgery, but surgery can cure prostate cancer. So if you have a localized prostate cancer that needs to be treated, hormone therapy, unless you're going to get radiation, really doesn't have a role by itself. Now, we occasionally will put a really old man who's likely to die from something else on hormone therapy, just to kind of keep the prostate in check, so that something else can get him. But that, even then, we wouldn't do that for a low risk or an intermediate risk prostate cancer. We'd probably do that for like a high risk prostate cancer that's likely to progress in a relatively short period of time. And we just want to throw a little bit of water on that fire, so that, natural causes can do its thing. But, even still, hormone therapy, when you lower the testosterone like that, does have an incidence of increased cardiovascular morbidity when people are on it for a period of time. And so, again, we have to weigh all the risks and benefits of these things. But as a modality to treat prostate cancer that's localized to the prostate, it really doesn't have a role by itself.
Okay. All right, thank you. All right, we have a few more questions here, and then I have one last question before we wrap up the evening. All right, next question. Can prostate cancer spread?
Well, we know it certainly can, like every other cancer. So it can spread locally, outside the capsule. It can spread to lymphatics. So for patients, they'll say, well, what's a lymph node? Well, if you have swollen glands, the lymphatics are filters. And so with cancer, that filtration is into the lymph nodes. The cancer cells can go into the lymph node areas. And we can see that with imaging, or if it's just microscopic, we don't see it. And of course, it can spread through the bloodstream, with the most common would be to the bone. Now, interestingly enough, what we're finding now is, with modern technologies, that even if patients have spread to the lymph node or to the bone, and usually it's 5 sites or less, there's still a cure. As Dr. Metwali had said, if we have a patient who's 75 and he's survived his cancer for 15, 20 years, Who knows what's going to happen in 15 or 20 years? But we're now curing these patients or offering very good long-term control. But those are the most common ways. Do we see cancers that spread to the lung? We absolutely do. We even see it to the brain, to other sites in the body as well. So, but most commonly through the bloodstream would be the bone.
Yeah, I think it's important to mention that the vast majority, vast majority of prostate cancers are adenocarcinomas. That probably doesn't mean a whole lot to people, listening, but there are some very atypical other kinds of cancers that can arise in the prostate, and they have a different sort of pattern of spread. You're talking about something even rarer than a zebra, but they do occur from time to time. But the standard run-of-the-mill prostate cancer is an adenocarcinoma, and we look at bones, we look at lymph nodes because those are like kind of the first two places that they go. And it's pretty, you have to have pretty advanced disease before you start talking about liver and lungs and so on and so forth.
Okay. All right. Thank you. Okay, next question, before we turn to the final question of the evening. This one, and I know we mentioned this earlier, is impotence a common side effect of radiation therapy?
So, it's a difficult question because a lot of it depends on the age of the patient and their function before. And which is very key because remember, the average age of someone with prostate cancer can be 68, 70, although with PSA screening, we're finding patients much lower. So with just radiation alone, the risk of erectile dysfunction is actually pretty low. And with modern technologies now, such as medications like Viagra and Cialis, patients can remain potent. And if there are patients that still have problems with erections, that's when I call Dr. Metwali and I ask him, what else can you do for this gentleman to help him with erections? So it's much less than it used to be. We're treating much less tissue. And now I'm actually learning from the surgeons some of the surgeries that they're doing to spare some of the blood supply, which also can affect erections. And we're doing those same types of things with radiation. So I think it's getting probably less and less.
He makes a great point because you cannot follow a cohort of men over 50 for a period of time and not find an increasing likelihood of having erectile dysfunction. You don't have to do anything to them. You just have to look at them. They just have to live the typical American lifestyle. And over the course of 2 to 5 years, you're going to find a significant proportion of them will develop erectile dysfunction. And so as we watch patients after radiation, figuring out like what's the natural progression of their erections and what is due to the hormones or the radiation itself is really, really hard to tease out. It's a lot clearer after surgery. Pretty much, and there's the other thing. There's what I call the chicken salad postulate. You can't make chicken salad out of chicken feet, If you got bad erections going into any treatment, they're going to be terrible on the backside. Right. If you got good erections going in, this is definitely not going to help. They probably won't be as good on the other side, but they'll be usable in all likelihood, especially when you start adding in Viagra and that kind of thing. But after surgery, your erections are really tough and they get better with time. The nerves that control your erections really don't love to be messed with. Most nerves don't. Maybe there's like a stretch injury or whatever, but the healing process. So what we find is that about 2 years after therapy, whether it's surgery or radiation, the rate of erectile function is essentially the same. So the question is whether you pay the piper up front or you pay it on the back end, but you kind of end up in the same place at about 2 years after treatment. How long it takes erections to come back after surgery is highly independent. Again, it depends on how your erections were to begin with. But we will, often put people on Viagra. We might use a vacuum erection device or injections or that kind of stuff to help maintain that part of your life. The goal of therapy is cancer control, number 1, continence, number 2, and erections, number 3. And it's in that order because the erections are the easiest to fix. Between Viagra, injectables, intraurethral suppositories, vacuum erection devices, and penile prostheses, we can restore that. That is a fixable problem. It just depends on what you're willing to do to get it. The continence is a little bit of a trickier thing. And then, of course, the cancer control is the whole point of this.
Okay. All right. Well, with that, I want to go ahead and just have you answer one final question before we wrap up the evening. And for this last question, I would like to know, what are your goals for everyone listening in on this webinar? What would you like our viewers to take away from tonight? And Dr. Greenberg, I will go ahead and start with you.
Well, I think several points. One is, understanding prostate health. Make sure that you get your PSA at the appropriate level, usually 50 years old. And if you have a family history or genetic disorder, which is not very common, certainly it's earlier, sometimes even 10 years before. And, listen to your doctor. Or if you see some of those symptoms like Dr. Metwala had said. And I think the other thing is, we are so blessed here at Jefferson Health to have great surgeons, great technology and radiation. So it's really the whole gamut of prostate treatment. It's not just one treatment or one surgery or one radiation. It's really what works for the patient. So it's really the total gamut of how to take care of prostate or not treating and knowing when to watch. So we're really blessed to have that here.
Thank you. And Dr. Metwala, any final remarks?
Yeah, prostate cancer is not, a one size fits all kind of disease. There's a lot of different treatment options, and some are more appropriate for certain stages of diseases than others. And so it's really, really important to make sure that you talk to everybody, get as much information as you can about the good stuff and about the bad stuff, because everything has bad stuff, and then make the best decision that's right for you and the disease that you've been diagnosed with. And there's a real smorgasbord of options here. And so it's really, really important to talk to surgeons, radiation oncologists, medical oncologists, talk to other people who've been through this, and get as much information as you can before you make a final decision.
For sure.
Absolutely. All right. Well, thank you so much, Dr. Greenberg and Dr. Metwala, for taking the time this evening to talk with us. I know such interesting information was shared and really helpful information. So we thank you. And we also thank you all for attending and submitting your questions. We will be posting an event survey so you can let us know your thoughts, any other specialties you would like to hear from. If you would like someone to contact you directly to schedule an appointment with a Jefferson Health provider, please fill out the last question in the event survey. Be sure to visit jeffersonhealth.org to make an appointment, stay up to date on upcoming events and webinars like this one and more. You can also visit jeffersonhealth.org/livingwell for more health content, patient stories, research, and innovation. Be sure to also visit the Jefferson Health YouTube page to view more wellness webinar series events. We have various topics from back pain to robotic surgery to hearing loss, men's and women's health topics, and much more. A recording of this event will also be sent to you so you can rewatch at your convenience. And if there is anything anyone here at Jefferson can do for you, please reach out to us. Thank you once again for joining, and please be sure to stay safe and healthy. Thank you.